Hello, I'm Dr. Nicholas Tedesco D.O, Co-Associate Program Director for Good Samaritan Regional Medical Center Orthopedic Surgery Residency Program. Today I'll be lecturing on biologic reconstruction following radical resection of bone tumors as part of our ongoing online lecture series to supplement the in-classroom case-based learning. I do have disclosures to make, and they are up to date at the AAOS disclosure site and are readily available to the public. So in terms of tumor reconstruction, anytime we talk about resecting a bone, you talk about, well, what do you do next? So option number one is always amputation if a viable limb can't be preserved, particularly if you have to resect major neurovascular bundles or too many muscle compartments to leave a usable limb. However, most often in the United States, when limb salvage surgery can be done, endoprosthetics are used. They're convenient, they're modular, they allow for immediate weight bearing usually, with the exception of the compress that some advocate for partial or no weight bearing for a period of time. They tend to have very good functional outcomes. However, they are extremely expensive. They're not ubiquitously available due to the rarity of cases, and sometimes it can take weeks for these to ship in to be able to use. They also demonstrate catastrophic structural failures over time, and there's limited familiarity with megaendoprosthetics in the community. So usually if one of these shows up in a small community center in the emergency department, there's no one there that can take care of it, and so care becomes very difficult in the long term for these patients. Additionally, there's limited salvage options when these do fail, and often may require amputation or an even more complex reconstructive surgery. So the next option is a biologic reconstruction, and that can be done either with grafting or no grafting on the bone itself. So with no graft, usually we're talking about distraction osteosynthesis or the masculate technique, but this does need an intact periosteum that can help grow new bone. You also can talk about spatial frames like an Alizaroff or Taylor spatial frame, and these need an intact periosteum, or you're going to have to plan for limb shortening by reopposing the two ends of the cut bone. Whenever we talk about grafting, we are talking about the actual use of bone grafting to the remaining healthy host bone for biologic incorporation and preservation of anatomy and physiology as close to normal as we can. We can talk about viable or vascularized grafting versus non-viable or non-vascularized graft. Additionally, we can talk in terms of allograft or autograft. One of the big problems with all of these grafts, though, is weight bearing needs to be protected until union because they're essentially a functional fracture, and this can take up to 36 months, especially when non-viable bone is being used. This will be the primary focus of today's talk. So when we talk about vascularized grafts or viable grafts, the advantages are that they're great for segmental defects. They provide immediate biologic osteoinductive properties. They provide immediate recovery of physiologic blood supply for better healing. Autografts can be local or rotational or free flaps and can include full osteocutaneous flaps if concomitant soft tissue coverage is also needed. You can also have allograft of this from specific donors when they're able to preserve their soft tissues well around the donor site. The disadvantages are obviously that there's a scarce supply of donors or autograft donor sites. Non-union, malunion, and late stress fracture are common. Donor site morbidity is an issue, and the high technical demands of the operation requiring microsurgery and often can take many, many hours to get through these cases. The non-vascularized or non-viable grafts are more commonly used because they're more readily available and a little bit simpler of a surgery. They're great for articular or massive metadiaphyseal defects. They provide immediate osteoconductivity and provide for biologic soft tissue reconstruction to native bone. The disadvantages are, once again, there's a scarce supply of donors and a heterogeneous procurement and sterilization procedures. Size mismatching is very common if you don't exactly get the right size to fit the patient or the defect that you created. Storage can be an issue, especially if there's a delay in surgery. There's variable immunologic responses to these, and you can get complete graft resorption sometimes or rejection of the graft. There's a high risk of non-union with these, malunion, avascular necrosis, fracture, and infection. So decision making whenever you're talking about tumor reconstruction and limb salvage surgery is always based on tumor prognosis, the remaining bone and soft tissue, patient age, cost, availability, and patient and family expectations. There's no algorithm or absolute indication for any of these, or for mega endoprosthetics for that matter. It's always a case-by-case basis. So the first thing we're going to talk about is going to be the allograft side of things. So we're going to start with intercalary allografts. These can be total or segmental versus partial or hemicortical. A partial or hemicortical intercalary graft will need fibular or femoral cortical struts to fit the defect, and they will need fixation with plate, screws, and or cerclage wires. A total or segmental intercalary allograft will need full diaphyseal segment of graft to fit the native bone. Femur and fibula are the most common used grafts. They must be fixed with plate, screws, and or cerclage wires. Intramedullary nails have been tried and can be trialed depending on the defect created, but they do have a higher rate of non-union. They can be too rigid of fixation. There could be too much blood supply disruption, both externally from the tumor removal and then internally from placement of the nail. There's often an obligatory malreduction, as the endosteal canal of the graft will follow the exact nail, which often can tip the graft even when it was cut perfectly at the level of the cortex to fit the defect, and it could be a combination of any of these above. Here's an example of an intercalary segmental allograft where they used a 3D printed custom cutting guide because the osteotomies are often multiplanar and complex, as well as the need for perfect reproducibility to fit the graft perfectly to maximize your bone contact. So they create a 3D cutting guide on the native bone still inside the patient there in image A. In image B, that's a 3D model of the tumor with the cutting guide on it. In image C, that's the actual allograft that's been chosen along with its own custom 3D cutting guide to be able to reproduce the same cut in that particular bone. Then in D, it's the resected tumor specimen in the proximal tibia. E is the allograft that's been cut, and you can see that it's slightly longer than the image in D, and that's because they're taking into account the kerf of the saw blade. If you don't take this into account, it's not going to fit properly. Then in F down there, they have it fixed with dual plating medially and laterally, and usually a bridge plating construct. Here's another example of a segmental intercalary allograft with an osteosarcoma in the tibia, where they're able to preserve the proximal joint surface and the distal tibia, remove that intercalated segment, and then fix it with the dual bridge plating once again. Then in D and E, you can see partial healing, especially of the proximal site, with still healing to go at the distal site of anastomosis. And then in F and G, you see long-term fixation with good incorporation into the native host bone. Here's an example of a hemicortical intercalary segment, where these are usually used for low-grade cortical-based tumors or a soft tissue tumor that is secondarily abutting or invading the bone where you can save one of the cortices. And so here is a adamantinoma involving the anterior tibia. You can see on the axial MRI there's good preservation of bone marrow, so the entire bone does not need to be resected, and you can save that posterior cortex and native host bone. Again, you see a complex multiplanar osteotomy has been done, and any more these days, these are done with navigation, with preoperative CT scans of both the native bone as well as the graft, and then planned custom cutting guides to reproduce these complex osteotomies and get the graft to fit perfectly. Then you get it fixed there with image C, and then in image D you can see the long-term follow-up with excellent incorporation and restoration of the bony structure. Articular allografts can be total or osteoarticular versus partial articular allografts. Total needs ligament and tendon reconstruction or repair because often you're not just removing the joint surface but the adjacent bone and the attaching ligaments and tendons. You can perform an end-to-end repair if the graft has at least partial ligaments or tendons as part of it. Otherwise, you'll need a full reconstruction with allo or autograft tendons. Partial needs a perfect match to prevent any intra-articular step-off. Again, you have to take into account the saw blade kerf, and this will need internal fixation, often with plate, screws, threaded Steinman pins, and even subchondral screws. Here's an example of several clinical full osteoarticular allografts. The upper left is a proximal ulna with the adjacent tricipital tendon and aponeurosis there to be able to incorporate back into the native triceps tendon. Then down below that, you have a proximal tibia with the remaining extensor mechanism. Quite often when you remove the upper end of the tibia, you have to at least remove a portion of the patellar tendon. You can either reconstruct this or include a graft like this and perform a patelectomy at the same time to incorporate this into the entire post-extensor mechanism and quadriceps tendon to reestablish better tendon-bone interface at the level of the tibial tubercle. On the right side there, you can see a full proximal humerus osteoarticular allograft with the joint surface up above, as well as preservation of some of the allograft soft tissue to allow for incorporation of the pectoralis, the rotator cuff, and joint capsule to provide better function and stability post-operatively. Here's an example of a full osteoarticular allograft where there was a large destructive giant cell tumor of the distal radius. After a full end block resection, the osteoarticular allograft is cut to size, applied and fixed with plate and screws. You can see good healing and incorporation long term. You do have some wrist arthritis and gapping of the DRUJ, but otherwise it does provide an elegant solution to allow for preservation of the hand and at least some function rather than an amputation or a full fusion. For partial articular allografts, these are usually done in younger patients where you're trying to preserve an otherwise very healthy joint surface with good longevity. So here you can see an osteosarcoma involving only the medial femoral condyle where the lateral can be preserved. However, you will need, again, this complex multiplanar osteotomy, so often navigation and 3D printed models are done for these cases. Here you can see the preoperative planning where they're performing that osteotomy to preserve the lateral femoral condyle, get around the tumor, and resect the distal femur. Then here is the finished product where you have that complex multiplanar allograft with the medial femoral condyle fixed in multiple planes and even augmented with a medial fibular strut, buttress, and graft augment. The next thing you can do is what's called an APC, or an allograft prosthetic composite, where you combine bulk allograft with a joint prosthesis to improve joint stability and articulation and to avoid the potential complex problems seen with avascular necrosis in a dead bone that's being inserted. It involves putting a hemiarthroplasty, usually seen in the proximal femur or humerus, versus a total joint arthroplasty anywhere you go, into an allograft and then mated to the native adjacent bone. There are lots of complications, as you can imagine, with both the graft or the prosthesis, but it's a home run when it works. Here's an example of a proximal humerus osteosarcoma where a resection needs to be done at the junction of the middle and distal thirds, where they then use a large allograft proximal humerus, but then a prosthesis to perform a hemiarthroplasty at the level of the shoulder. Once you incorporate all of this and get it to take, it usually ends up with a very good solution and bypasses one of the modes of failure of a large articular allograft. Again, here's a total joint arthroplasty now with a proximal tibial osteosarcoma. Once the tibia is resected, a large allograft is placed with a total knee replacement. However, because the proximal tibia is removed in its entirety, you remove the stabilizing ligaments as well, so the patient gets a hinge for this particular construct. So here is a good preservation of function and anatomy without requiring a massive endoprosthesis. Now we're going to switch gears to the autograft side of things. The first autograft we'll talk about is the vascularized fibular autograft. This involves harvesting the shaft or proximal portion of the patient's fibula, or both of their fibulas if needed. They can preserve the proximal physeal plate to use in a growing child if needed, and you can also do a full osteocutaneous flap if concomitant soft tissue coverage is also needed at the time of the reconstruction. You will need to reconstruct the posterolateral corner of the knee if the proximal fibula is removed, because this will destabilize the lateral collateral ligament as well as the popliteofibular ligament, or you'll need to perform a proximal fibula Salve-Capanghi type fixation procedure of the fibular head to the proximal tibia if it is preserved with no adjacent shaft. Depending on the length of bone harvested, you can often see distal fibular proximal migration and valgus destabilization of the ankle, so you need to consider concomitant syndesmotic fixation, especially once you're getting past the mid-shaft of the fibula. The graft will usually hypertrophy over time to match the new area of bone within reason. It's often difficult to get the fibula to reapproximate the mechanics of the load-bearing portions of the femur, and so many times in those areas they will use what's called a double barrel graft, or basically two fibula grafts, either the same shaft cut in half or the second fibula harvested as well. Here's an example of how the osteocutaneous allograft is taken with the blood supply from deep from the peroneal vasculature. Because of its relationship with the flexor hallucis longus, this will need to be harvested with the bone and skin as well, but it allows you to preserve both. Here's a schematic on the left of a fibular harvesting where all the perforators arise from deep, with the main perforator usually right around the mid-shaft of the fibula. You can take any portion of the fibula that you need or however much length, and then on the right is the schematic of the osteocutaneous flap where you need to take it with the adjacent flexor hallucis longus to preserve that longitudinal blood flow that provides the deep to superficial flow all the way to the skin. Here's an example of the use of that for a distal tibial osteosarcoma with concomitant ankle fusion. You have the contralateral midshaft of the fibula harvested to jump the gap, then you fix it with a bridging plate. You use the ipsilateral fibula for part of your ankle fusion, and you're able to reproduce good physiology and bone healing right off the bat along with load-bearing mechanics as soon as it is healed to provide excellent stability and limb preservation to avoid a below-knee amputation. Here's an example of a complex tibial defect where they actually used a plate and screws as an external fixator to jump that gap. They then harvest the ipsilateral fibula and transfer it over there. You can see in the upper right images that the fibula is grossly undersized compared to the native tibia. However, once it's healed and incorporated in the bottom left there, it hypertrophies and tibializes to look more like the native tibia and provide better load-bearing mechanics as well as limb length preservation. The next vascularized autograft we'll talk about is a femoral vascularized autograft. This autograft is often used after salvaging the unaffected femur during an external hemipelvectomy for complex spinosacral pelvic tumors. These are used to reconstruct the lumbar spine or to re-anchor the spine to the pelvis if a sacrectomy is performed. These can be massive surgeries, some of these lasting up to 36 hours, depending on how complex the reconstruction or tumor resection is. So these are usually only done with curative intent in a patient healthy enough to tolerate such a surgery. Many complications arise related to the graft, but really more so to the surgery itself. Here's an example on the left side where instead of creating a free flap, they actually create a rotational flap of the midshaft of the femur, where they rotate that up with its vascular pedicle into the pelvis. So this is where an external hemipelvectomy with partial sacrectomy has done, so that has at least partially destabilized the connection of the lumbar spine to the sacrum. So when they rotate that shaft of the femur up as they remove the limb, they're able to fix that femoral strut to the S1 vertebra that's remaining, as well as the L5 and to the pubic symphysis, to reestablish a better and more solid connection to allow for stable sitting on the contralateral ischial tuberosity. On the right side, you can see they actually used a free flap where they harvest it from the native femur, but you're preserving the legs here, so usually you're going to jump that gap then with an allograft into the native femur, and then you're going to rotate that autograft up here where you really need better biologic growth and fixation because of the gravity of the situation, where they've performed a complete sacrectomy with partial iliacectomy. And so you have complete destabilization of spinopelvic mechanics. This way you can attach the strut graft to both iliac crests as well as the lumbar spine to reproduce a connection there and provide for stable spinopelvic mechanics. Here's an example of one that was used to recreate an ipsilateral ischial tuberosity to allow the patient more comfortable seating. Normally when you perform a full external hemipelvectomy, they have to lean to one side to sit on only the one ischial tuberosity, which gets very uncomfortable over time. So here's where they're able to get that to incorporate and heal to the sacrum as well as the contralateral pelvis to provide a second sitting surface to allow a more level and comfortable sitting environment. The next autograft we'll talk about is something called a Clavicula pro Humero. This is where the medial clavicle is released either via osteotomy or disarticulation at the sternoclavicular joint and then turned down to reach the resected portion and bypass the proximal humerus that has been removed. This makes the AC joint the new shoulder joint. This is most often incorporated in young growing children too small for an endoprosthesis or with too much growth remaining for a growing endoprosthesis. Complications include proximal pseudarthrosis, which is the most common complication, as well as non-union, fracture, or even glenoclavicular fusion from heterotopic ossification. Union times approach 2 years with this procedure, so you often need to augment this, often with a vascularized fibula or other strategy required to get these to heal better and faster. These are often not long enough depending on the level of resection, and if so, you will need an additional intercalary graft. Here's an intraoperative photograph of a Clavicula pro Humero. You can see the blue line there is pointing to the AC joint of the two images, where lateral is on the left side of the image and medial is on the right. The clavicle is in its native position in the left image and then turned down in the right image after being released medially. Then you can see the neurovascular bundle there clearly, where the humerus has already been resected. So here are some radiographs of this successfully being done. In the left side here, this is one where additional grafting was not needed. The resection was small enough where the clavicle could jump the entire gap and be fixed adjacent to the native humerus. Then the images on the right are one where you needed to resect at the level of the middle and distal thirds of the humerus, which is too far for the clavicle to reach, so they've included a concomitant intercalary vascularized fibular strut graft that can be plugged into the native humeral vascular bundle. The last type of autograft that we'll talk about today is the pasteurized autograft. This is where the tumorous bone is resected, sterilized, and then immediately reimplanted as part of the same procedure. It can be frozen or heated, autoclaved, irradiated, or chemically treated, usually with anhydrous alcohol. It does need to return to room temperature and be thoroughly irrigated before implantation, and it's often augmented with iliac crest bone grafting at the osteotomy site, because essentially this turns it into a non-viable graft, or basically a large allograft. But because it's the patient's native bone that has just been removed, it provides a perfect fit anatomically once you put it back in. This is also preferred in many East Asian countries for socio-religious reasons. Similar risks to a devascularized allograft. However, there's the theoretic risk of recurrent tumor. This is difficult to prove in any study because the studies tend to be too small, and there's always a risk of recurrent tumor even if this is not used. But you can also combine this with total joint arthroplasty to avoid the risks seen with avascular necrosis of these pasteurized grafts around joint surfaces. So similar to an allograft prosthetic composite, you can see here there was an osteosarcoma in this distal femur with the increased sclerosis and the cortical changes there in the medial cortex. And then not only did they fix it to the adjacent bone, but they were able to input this rotating hinge total knee replacement and provide a very long-term elegant solution here where the plate has now been removed. You've got excellent reincorporation of the bone and preservation of the adjacent anatomy. Here's an example of successful pasteurized allograft where you have a midshaft pathologic fracture through a focus of Ewing's sarcoma. On the right, in the upper portion there, you can see a vascularized fibular strut has also been placed in the intramedullary canal to augment this, but the pasteurized bone has been reinserted with the periosteal reaction and lytic portion of the bone noted there in the mid portion. Then on the bottom left, you see partial healing over time, and on the bottom right, the incorporation over time with mature healing and re-establishment of the femoral shaft while preserving the patient's native anatomy. Then when it's not so successful, you can have some very catastrophic complications that will obviously require further surgery, whether more grafting or mega endoprosthetics. On the left here is an example of severe AVN with a condylar fracture. Then on the right side is an example of near complete graft resorption and structural failure as a result. So one of the things about all of these grafting procedures is quite often augments are used or required just simply because they take so long to heal and the risks of failure are so high. So things that are commonly employed that need to be considered whenever you're doing these procedures are things like BMP2 or Infuse. Then you can try bisphosphonates or denosumab to prevent bone resorption, iliac crest bone grafting, bone void fillers such as DBM, calcium phosphate, cancellous chips, bone dust, or PMMA if there's any large gaps or internal defects. Then, of course, you always want to avoid anything that could theoretically mess with your bone healing, like NSAIDs or stimulants, including caffeine, nicotine, amphetamines, cocaine, all the fun stuff. So with that, I'll leave you with my Pacific Northwest Pride slide. This is Dorino Lake outside of Cottage Grove, Oregon, which is actually a reservoir created by a dammed up river. It's a great place to get a small hike in or enjoy a nice picnic lunch for an afternoon. Thanks for listening.